So in the presentation today, we'll be talking at a level set of BPCI Advanced, but then we'll get more specific into episode creation, how things are attributed. I think you'll find some very interesting material in the financial side of BPCI. I've certainly heard a number of questions around that as I've been interacting with you. So we look forward to giving you some insight there. Jerry will have a piece on care redesign and the really innovative, creative things that can be done there. And Jerry also has some very valuable insight he's gained recently with the legal aspect and the waivers. And certainly at any time, if you have questions, email us directly, or you can see our general email here. So let's get into the BPCI Advanced overview. Some of you have been in the Classic and you're well familiar with this. This is old hat. Others of you have been are new to this. So we can meet you where you are. We have flexible systems for you based on where you're at with your journey. But as I look at the different elements that support a bundled payment, as you read that column there on the left, it's interesting to me how payment reform leads to provider reform. When CMS or a payer creates a financial incentive for us as providers to be able to execute a program with an economic ability, then things start to happen. And that's exactly what we've seen in BPCI Classic. And I think it's very telling when you look at the recent quote from CMS Administrator Seema Verma. And I had a chance to be in a lot of these meetings when I was in the think tank, and to hear her and others talk about their value for bundles and why they want this to keep going forward for specialists. I'll just note one quote. She said, BPCI Advanced builds on the earlier successes of bundled payment models and is an important step in the move away from fee-for-service and towards paying for value. So this clearly is a way, bundled payments, to get specialists engaged, to have a coordination through an episode of care, and to have them engaged, to have us engaged in advanced alternative payment model. So these types of things naturally happen in the bundles. We'll go to the next slide. So this graphic illustrates the episodic nature of a bundle. It starts with an anchor hospitalization and ends 90 days post-acute. So everything that would come into that, from the surgeon, the hospital, and anything post-acute, skilled nursing, inpatient rehab, LTAC, outpatient therapy, all of these charges are billed customarily by each provider to CMS, and then the sum of those charges is reconciled on a semi-annual basis against a target calculation. So let's just use an example. This is hypothetical. Say CMS provides a $20,000 target calculation. If the sum of everybody's bills is in excess of that, or if it is lower than that target calculation, let's say it's 21 or 19. If it was 21, then the episode initiator, the bundle owner, is going to have to pay that money back to CMS. If, however, the sum of the spending is less than that target calculation, less than the 20, let's say 19, then that amount is paid to the convener and to you as the episode initiator. So that's the basic tenet, the overview, if you will. It's an aggregation of claims, and it's retrospective. CMS retrospectively, biannually adjusts and lets us know if we have, by patient, overspent or underspent. We can go to the next slide. So it's interesting with BPCI Advanced to look at the rules, and we'll get into some of these nuances, and Jerry will give a lot of very specific insight that's valuable to you. It really is, in Advanced, the culmination of all of the lessons learned in Classic. And I would back up even before that and say ACE. When we look at the history of the demonstration projects, everything has really culminated here in this Centers for Medicaid and Medicare Innovation program of BPCI Advanced. It's the best of, if you will. Now, it's certainly not a perfect program. Jerry will talk in this presentation about a couple of things that we are trying to bring about, clarification on rules. But it is in many ways, it is a better program than Classic, and it is a very engaging way for you to earn incremental revenue, have a better coordination of care, and have a path towards advanced alternative payment models in macro. And we'll talk more about that in these ensuing slides. So if we look at a high level of who can participate and which patients are included or excluded, this is a 10-level participation model. So physicians are not able in a group individually to say, yes, I'll participate, no, I don't want to participate. But what you can do through your group is say, we would like to participate in this bundle, not in this other bundle. And there are some periods along the way, starting in 2020, where you can add or delete bundles, and we'll talk more about that in detail. Some patients are excluded from this model, though. We're going to talk in more detail about CGR, the track 3, and next-gen ACOs that have the two-sided risk. So we'll tee this up at this level, and we'll get more specific here in a moment on those participation elements. So I'll defer to Jerry here in this slide that you can participate both as with a convener or as a non-convener participant.
So what we're showing here is the 3 types. Everyone will be an episode initiator who's going to be a provider who's going to have episodes that start. Essentially, it's your orthopedic surgeons and your practice that will be the episode initiator. An episode initiator can also be a convener or a non-convener participant, as they will, but they don't have to be. So Fusion5 is a convener. We are not an episode initiator. We will convene for a number of other episode initiators. A non-convener participant is somebody who will convene for themselves and only themselves. So a single practice could do this, or a single hospital for just the hospital, where they're both a non-convener participant and an episode initiator. This is just to set the stage on definitions about the terminology that is used between them. You will hear convener and episode initiator a lot. So the easiest thing to think about is Fusion5 is the convener. You, the individual practice, is the episode initiator.
So we have a timeline here for you. As you're aware, the application due date came and went, and we are very grateful that you are considering Fusion5 as your partner in this journey. And we have next coming in May the target calculation methodology files that we will be receiving from CMS, and Jerry, you can give some insight on that.
So yeah, you'll see these little starbursts next to things, and that's generally reminders that there's new information relative to this. And so target prices and historical data will come sometime in May. CMS, as typical, will not define when in May. So if I had to make a guess, it would be the very end. You'll notice right underneath that it says initial applicant triage. The Innovation Center will triage out applicants who did not have an adequate application, whatever that means, and they will no longer be allowed to either be a non-convener participant or a convener in the program. That will be clear because they will not receive any of the data and target pricing. Those that do receive target pricing and data will have passed the first step in this process. They're doing this as a multi-step process, so there'll be a later event in this timeline that you'll see as Sean goes through that I'll add on to at that point in time. We also hope to receive a little bit more information about the target pricing methodology, which will be the generation of a portion of an upcoming webinar on target pricing itself.
There are, as Jerry has mentioned in prior webinars, a number of what we would call black boxes that CMS has yet to provide, or information that they exclusively hold. So we will receive that information in May, and then be able to very accurately forecast what are the bundles that are safe for us and what are the ones that we should shy away from. A lot of detail will come into that specific to your market, which is why we're setting up individual meetings with you. But we can tell from a very high level, what is your inpatient rehab facility utilization in a given market? What is your skilled nursing facility utilization by bundle? These types of things can quickly change through our clinical team and our regional operations team, and we can help bring those changes about to produce changes for you very quickly in your financial performance. So these are the types of information that we will receive in May. In June, there is a participation agreement that we receive, and that has with it your quality measures, your composite quality score. We're going to talk more about that in an ensuing slide. In July, there are some deliverables with the participant profile, care redesign profile, the financial agreements, in other words, who you'll be gain sharing with. We will help put all of that information for you together in July. And that is because of the fact that in August, the submission is due. So that is the comprehensive list of everything I just mentioned. And in addition to that, there's also a law enforcement screening document for anybody that's participating in the program. All of that then gets reviewed by CMS. They give a final determination status in September as to participation. And then the go live is October 1st. And it's of note here too, the first time that you will have the ability to add or delete episodes will be January 2020. So the first year of the program, in essence, is 5 quarters, Q4 this year, and then all of next year. And sometime in 2019, CMS will provide us information on the ability and the rules to add and delete episodes. So those are some key dates.
So one of the things that you'll notice on that September 3rd date where it says final applicant selection, that's the second half of the triage portion of what the Innovation Center and CMS will do for its applicants. Ultimately, at that point in time, you will know whether you are going to be an episode initiator and or a convener in September. Quite a time off from the initial application, which was in March, and the other information that's released in May and June. You'll notice that on October 1st, there's a starburst also next to the start date, and this is one of the things that I think is important for everyone to realize. Language came out from CMS indicating that unlike BPCI Classic, for those who are familiar with it, while an episode is initiated with the anchor stay in the hospital, the date of admission to a hospital for an episode, in the advanced program, the performance period that episode will be considered to be part of will not be determined by the initial anchor stay like it was in Classic, but rather the end of the episode, the last day of the 90-day post-discharge period, very much like CJR was done. That put an interesting conundrum in terms of Q4 of this year, because episodes that end during Q4 would have started somewhere during the summer, when you as an episode initiator have not even determined that you will be part of the program or not. And it is also an overlap time between BPCI Classic, because their episodes would start all the way up till September 30th. So essentially what the Innovation Center has determined is that because of that, there will likely not be any episodes that terminate in Q4 that will be part of BPCI Advanced. And it will be those that actually, the anchor stay started on October 1st or after, which will be part of the Q1 reconciliation period for 2018. So the key element is one does not have to worry about do episodes count and are we at risk for episodes that started in August that end during Q4. The answer is no, you will not be.
So these types of nuances are a good illustration of our request to meet with you as soon as possible. I know Martha from our office, and we have others that have been reaching out to you If you haven't already scheduled a time with Jim or Jerry and some of our regional team members that are visiting, please do that now so that we can get all of these details organized and all of these different elements. We'll also be at the OrthoConnect show next week, and we'll be reaching out to you on that. Let's talk a little now about the episode creation and patient attribution. It was interesting to me how CMS went from 48 episodes in Classic to 32, and how of those 32, 3 were cardiac, and excuse me, 3 were outpatient cardiac. So it's the first time that we've seen the introduction of outpatient. So Jerry, perhaps you can lead us through that, and then the next slide also relating to that.
Sure. And so, you know, it was very clear that 48 episodes from Classic were not all that well suited for bundle payments. And so the ones that were not engaged in or did not seem suited, they tended to drop. The outpatient episodes was an interesting addition. Glad that they've actually done it, as Medicare is starting to learn that several things can be done outpatient. And the starburst is actually here because many of you have had questions about the removal of total knee arthroplasty, or TKA, from the inpatient only list and the impact that that will have. I can tell you that CMS and CMMI are still working on the impact and trying to determine how to make adjustments given that the outpatient version of TKAs is not currently part of BPCI Advanced. Partly because they have no method to determine a pricing structure because there has been no outpatient bills. It's not to say that it may not be added in the future, and I could easily anticipate that that might be well considered for January 1 of 2020 when they have enough data in order to come up with a pricing structure for the outpatient portion of those. As I said, the Innovation Center is trying to determine how this will affect target pricing, knowing that a portion of what could well be the lower cost patients will be removed from the program, and therefore your population of knee patients is likely more complicated and could have a higher cost. They're working on methods on how to adjust for that, and we're going to try to help them along those lines. It should be noted that despite what you may be hearing from the community and certainly from hospitals, is that the providers, the orthopedic surgeons, the physician groups, are the ones who decide and determine what the clinical rationale is and the qualifications for a total knee arthroplasty to be inpatient or outpatient. There might be some additional hoops and hurdles in order to fill out the appropriate paperwork for a hospital for inpatient. However, it is up to you to make that determination. It is not the facility's choice to determine that. And therefore, what we're going to suggest to all of the groups is to set a defined criteria for what is an inpatient and what is an outpatient total knee arthroplasty, and be rather stringent on how you do that and what those clinical criteria are. And that will be your determining factor, and you always then have a document to fall back on in terms of what that determination is. And use that as a guide for whether your patient population for any given patient is to be done inpatient or outpatient, and it will carry on. Obviously, because they was taken off the inpatient only list, those patients are now subject to the 2 midnight rule, but there is no auditing process for the first year that will go on for that, and part of that is to determine what the actual length of stay should be, and should there be a compensation based on that. CMS and CMMI are well aware of the impact of the 2 midnight rule and how that could actually adversely impact even those that are done as an inpatient because of billing. So just know that those things are currently being addressed. The remainder of this slide we've actually quite covered before in terms of linkage, or they will appear in more detail in future slides. So I wanted to move on to this slide. This is here for a couple of things. These are examples. This is an orthopedic webinar at this point in time, so highlighted at the top are a sample of the most likely orthopedic episodes, especially for those who are not familiar with BPCI Classic, as to what types of episodes we will be looking at when we do data analysis. This is not the entirety of the list. I have put other episodes on here that would be of interest in both major medical and cardiac episodes as a concept and an idea that we at Fusion5 are also working with hospitals. And in your markets, if we're not working with a hospital, perhaps we can use your assistance on engaging with the hospital to engage them in BPCI, if not now, in 2020, and use that as leverage to create better alignment between you, the physician group, and your hospital or hospitals that you are at. Because of precedence language, the physician groups will always take precedence over the hospital, so there's no problem with the orthopedic episodes that you will choose, but rather we can engage with them on those that you're not doing, perhaps, and those things that lie outside of orthopedic. So this is here just as a future thought process for continued engagement with your local environment and perhaps the ability to generate better alignment with your provider facilities.
One thing I'd like to add here is the collaborative nature of Fusion5 that I really appreciate. You know, I've worked in the industry now for almost as long as the program is old, and I'm sure in your local markets you've seen different approaches. You know, you've seen some gamesmanship, if you will. Some conveners like to just own the bundle and make sure that other people aren't participating, et cetera. In contrast, what I've seen with Fusion5 is exactly what Jerry just articulated, and that is the spirit of collaboration. You know, the fact that we can work with cardiac providers, the fact that we can work in internal cost sharings with hospitals, and we'll talk about that in our finance section. You know, these are all collaborative ways that Fusion5 puts forth, and I appreciate the culture that Jerry and Jim and Sue and others bring on this, and I hope that's illustrated here. So a key development here to talk about is what Jerry covered, so we'll just hit this high level, which is precedence. In Classic, you had a different type of precedence. In Advanced, you have such that Jerry said the physician group is in the driver's seat. So you do have some, nonetheless, patients will be excluded. You have the CJR patients, and Jerry will talk more about that. You have the Vermont and the Maryland ACO, or all-encompassing models. Now, there are some exceptions to that. Say, for example, you're a practice in Maryland and you do surgeries in Delaware. The surgeries you do there can qualify, and that is a change from Classic as well. But there's this nuance, and I'm sure many of you have this question of, okay, I'm in a CJR market, or I have a next-gen or a Track 3 ACO in my market. They take precedence in Advanced. What does that mean for me as a physician group practice? And Jerry, perhaps you can touch into that.
Yeah, so what it means right now is that any episode that could be initiated in a CJR market will certainly go to the CJR hospital. It will not enter BPCI Advanced and become a BPCI Advanced episode until the end of CJR. That will be at the end of 2020. It does not mean that you as a practice, if there are additional episodes that look like they will be of value, should not also put in for the same episodes, which is lower joint replacements, or DRGs 469 and 470, in BPCI Advanced. You will not be attributed the episodes, but when the time comes that CJR ends, it will automatically flip. And by doing it from the initial get-go, we won't miss any deadlines and have a gap. And that's an important part. We don't want to miss something downstream. In terms of CJR and the ACOs, these are all also advanced alternate payment models with both upside and downside risk. We've gone back and forth with the Innovation Center and CMS on the rules behind this, and right now they're very straightforward that the ACOs, Next-Gen ACO and the MSP Track 3 ACOs, along with CJR, will take precedence over BPCI Advanced. We are still working on trying to get them to understand why that is less of a good idea than they think it is. And there's some issues between the interpretation of data, between data that groups like Fusion5 can produce and submit, and that which the feds and the Office of the Actuaries are producing. And one of the things that we need to do is reconcile between the two parties which data is actually real. And so that's still ongoing, so don't give up hope. But right now, I think we all work under the premise that the ACOs and CGR will take precedence and figure out what we can do during the time frame that that is true, and what that means in terms of episodes for BPCI Advanced for any individual physician practice.
So we've talked on the left on portion of this slide that the physician group practices will have precedence over hospitals. What's interesting to me is the right aspect, where you have the UB04 facility charge from the hospital, and depending on who they note as the attending will determine the bundle owner. And Jerry, I know you have some unique information that you've gained even of last week.
So this here is a point of contention that I brought up on a visit to CMMI in Baltimore. And there's a lot of you that are out there, and I don't know if anyone happens to be on the webinar who is part of this and has heard, but there are rumors abound about organizations trying to game the system between attending and operating. And we will have some additional information upcoming in a future webinar that details this a little bit better. There's some information that we still need to gather that really lends itself to determining what the real content is going to be. But one of the things that we are concerned about is having an understanding that the individual hospitals are in fact filling their UB04 forms out correctly to start with. We know that in the past this has been less than ideal in many locations. I know of one particular example where I'm not going to mention the group, but where historically a UB04 form has been so mucked up in terms of the way it's been filled out that if you use the attending field, the anesthesia group would have been attributed the episodes for lower extremity joint replacements, as opposed to the operating surgeon, the orthopod, or any particular attending that was actually an attending at the hospital. And those are the things that we'll try to identify. The unfortunate portion about anything that goes on a UB04 form is nobody actually gets to see it. We've had limited success trying to get UB04 forms in the past to actually review. They get submitted by the hospital to CMS and paid through the MACs, and rarely do they become something that gets proofread, so to speak. I'm trying to convince CMMI that there's a good reason to actually do that, but don't know how much success I'm going to have with that. So we'll have to see. That'll be an ongoing discussion with CMMI, and future information will be forthcoming.
And it seems that a lot of this will play out market by market, depending on how your facility codes, your hospital codes. And those are certainly conversations that we will help you facilitate with the hospital. Well, I see we've got about 20 minutes left, and we've still got a lot of meat on the bone, a lot of insight we want to give you. So we'll probably go through these remaining slides somewhat quicker. The financial side of Advanced is interesting in that it is now a semi-annual reconciliation. It can, Advanced, meet the determination for MACRA to be a qualified provider if you meet certain volume thresholds. And there is the opportunity continued with internal cost savings. And if I may on that just highlight a personal thought, I've seen just from the DC perspective, different conveners and how they approach internal cost savings. And I can say that many don't. So this is a key question as you consider Fusion5. I've seen that Jerry and Jim and Sue have executed the ICS at a very expert level. And there can be, and we'll show this in our financial in a couple of slides from now, we have an illustration on this, it can be as much from internal cost savings in some cases as you gain from your NPRA. So really three forms of revenue here for you, from your NPRA, your internal cost sharing, and then your MACRA. And that's quite a nice feature on MACRA, that you can have the 5% upside rather than be subject to the plus or minus up to 9% by 2023 downside. And Jerry, if you want to give some insight on MACRA.
Yeah, I was going to just expand, and we will have a more in-depth discussion in a future webinar on the MIPS MACRA. deal. What I wanted to mention here is that the Innovation Center has a task force specifically set up for MIPS and macro regulations and how this program will impact physician groups as well as hospitals and their attestation, if you will, for macro qualification and their QP status. There's a couple of complications that are within the system that I don't think that they fully vetted out that I brought to their attention. And they're still working on what that actually means and how everyone is going to be judged for macro. So hence the starburst over here. Forthcoming information, we will include that in a future webinar.
So your money that you will receive as a practice in Advanced is tied to quality performance targets. Now there is a 2020 factor that you are not required to submit any quality information to them, that will all be gained from claims, but there nonetheless can be a 10% adjustment to your amount that you receive. So Jerry can talk about that a bit here.
Yeah, so where I was going to go with this one was not so much the mandatory targets, but rather for those that were in BPCI Classic, especially with where we were, there are quality measures that are important for the gain sharing aspect for the episode initiator as well as the practitioners to receive gain sharing funds. Those will be part of this and will be likely a similar type of selection. The program itself has required mandatory measures, and this is where Sharon was getting in terms of the possible 10% ding that one could get if one doesn't meet the qualifying threshold on those mandatory measures. And they'll be coming up in the next coming slides. The key element on gain sharing is that quality is part of the program as it is with any of these demonstration or initiatives. And the gain sharing components as well as care redesign is possible because of the legal waivers to the fraud and abuse laws, which are listed here. And I'm going to carry this over to the next set of slides, so I think it's just easier with flow in terms of, we talk about revenue sources. We showed a slide before that had 3 that included MACRA. For the sake of what's left here, we're going to talk about the 2 revenue sources that are part of this program, which is net payment reconciliation, or NPRA. That's the savings from Medicare relative to your target price. ICS, or internal cost savings, are the savings that can be generated internally at the hospital level that you can gain share on a portion of the savings as allowed by the OIG and distributed according to the rules of the program. The episode initiators can receive the bulk of the funds. Obviously, if you have a convener and whatever the fees are, there's a fee taken out of that by whoever that is. The physicians themselves can gain share up to a cap of 50% of their pro fee, so to speak. It is actually their allowable spend, but if we just think about pro fee, it's a little bit easier. Everyone kind of knows what that is. The fraud and abuse waivers that are part of the OIG determination will allow this gain sharing to take place. In order to qualify for any type of sharing, and what level it is, the mandatory measures come in. And these are the initial 7 mandatory measures, 2 of which will apply to all episodes, the first 2. The other 5 on here will apply to specific episodes of care. Which episodes of care they apply to has not been released. It is supposed to be released sometime in May. Because it would be nice to complete this chart so that everybody knew what they apply to. I'm pretty sure that the one that refers to TKAs will be something for lower extremity joints, so that would make perfect sense. Some of the other ones are a little less descriptive. One of the reasons that the starburst is next to this is you'll notice that the first measure, which is a mandatory measure, is the all-cause hospital readmission measure. Now, you may be thinking that as an orthopedic practice, I can have perhaps an influence on readmissions and the readmission rate for the orthopedic patients that we see. But I have no ability to influence any readmission that occurs at that hospital for any other episode, especially those that are non-orthopedic. But they're going to count in the way the hospital measures are done. And this is known by the Innovation Center and CMS. One of the things that they had to do, because they did not want to put an additional reporting burden on any participant, is they had to find measures that they could assess out of claims. and these were the ones they came up with. It's not to say that these might not be altered in the future to be more applicable for hospital measures to be on a hospital basis and physician group measures to be on a physician group. So just know that this is where it's starting, but not necessarily cut in stone. This slide here has a lot of bullet points, if you will, 1 through 5 are bullet points. The key element here is the mandatory measures can have an influence on reconciliation. When the quality, composite quality score, what's called the CQS, which is in bullet 3, is determined, the level of that score will determine whether there is any impact on the reconciliation amount, whether you will receive as an episode initiator the full amount of the reconciliation or a reduced amount up to a maximum of a 10% reduction. That's where the 7 measures from the previous slide come in. We will likely include this in a future webinar as more clarity is generated on how this is being calculated and what the impact will really be. And lastly, in this section, I just wanted to walk you briefly through how the funds flow in this. I'm not going to add any dollars to this at this time. That will be in I believe it's the next webinar, but one of the next upcoming ones will put dollars to this and show you exactly how this works. But essentially, these are the 2 revenue streams. We're not doing MACRA. NPRA, or the net payment stuff, that's the savings from Medicare, is on the top. If you are below target price, and this is in the aggregate for a performance period, so a 6-month period of time, CMS will forward that difference between actual cost and target to the convener. The convener will then deposit funds into a savings pool for that particular episode initiator. Those are accounts that we hold. Obviously, whatever fee a convener would have, whether it's Fusion5 or anybody else, will come out of that. What goes into the savings pool is then generated to go to the episode initiator, in this case, a physician practice in orthopedics, to distribute a portion to the gain sharers, which are the physicians and anyone else that is designated as a gain share, and the remainder to be retained by the episode initiator to offset overhead. The second revenue stream is internal cost savings. If you have the appropriate arrangements, which are done between the hospital, the convener, and the collaborative of the episode initiator and the physicians. When that is reached, if savings are generated in the hospital, and for orthopedics, one of the easiest ones to describe is implants. It's not the only one by far. If we can reduce the costs, a portion of that savings or all of the savings can be generated and delivered to the savings pool as well as a second revenue stream. The distribution out from there is the same as it was before. The reason to have internal cost savings is it adds to the global savings of the program, increases the dollars in the savings pool. ICS can be used only to fund the physician portion of gain sharing, that goes out to the practitioners, but it does increase the amount that is retained by the episode initiator, or in this case, the orthopedic practice, for offset of overhead and running the program. So there is a great benefit to having both revenue streams available to you.
I'll add one thing here on that slide with the funds flow. 2 things. One is the advantage to the hospitals. The other is what Jerry just touched on, and the overall impact to the practice. For the hospitals, there's tremendous gain of alignment that can be had in those internal cost sharings, quite significant. And you know, when I worked at the hospital, many years ago, they've started the just-in-time, the Six Sigma, the Toyota, the Lean Design, all of those programs. So implementing these internal cost savings is something that's right where they want to be, and certainly creates a nice financial alignment for the hospital. And then secondly, with what Jerry mentioned on the overall impact to the practice, the physician is limited to 50% of his or her professional fees. So let's say there was a $1,400 professional fee, and there's more than that in savings, but he or she could only get $700. The excess amount of savings then goes to the practice. So that benefits then the sports medicine, the hand surgeons, and really reduces the overall costs within the practice. So the whole group can benefit from this participation, and the hospital can align in very effective ways.
All right, thank you, Sean. So that brings us to the brief overview of care redesign. We're going to do this very briefly and relatively quickly. There are a couple of upcoming webinars that will be specifically on care redesign efforts and care coordination. So this is really just to touch on the highlights. As you have likely all seen, Fusion5 is built on 5 core services, one of which is highlighted in yellow as integrated care coordination and care redesign. And the question is, what does that really mean? It has several components that are part of that, and you can see all of them here in terms of the care management and tracking system, the intake process for both elective and emergent, predictive pathways, evidence-based medicine, and so on, right? So these are all elements that go into the redesign of care as you may have been used to doing it. Those are have been in BPCI Classic will be familiar with this care redesign route. Those that have not, there is a paradigm shift that will go on in terms of how patients are managed and what the thought process of the practice and the practitioner, the physicians are, in terms of getting out of, we do the surgical event in the hospital, they come back for follow-up visits, to we're concerned about the patient holistically as a whole during the episode, and even that 4 to 6 weeks before the episode begins, when we can really investigate the patient, learn more about them, and ideally optimize the patient for whatever the procedure is that is necessary. That will be all part of upcoming information. Care redesign is everything that's around the outside in this particular graphic, in terms of all the components that go into it, from psychosocial and comorbid condition management, post-acute care management, the clinically predictive model, all of which surround and are centered by the coordination of care, right? So care redesign involves a paradigm shift in terms of the ability to manage patients and manage care. It is centered on care coordination in order to do that management. And this shows a stepwise workflow across the care coordination process on an extremely high level in terms of understanding patient eligibility, what steps go on through the continuum of care in terms of risk assessments and understanding the risk profile, to developing a care plan for that patient, an individualized care plan, not something that is generic. It's not a one-size-fits-all like certain SOCs are. Through patient education and through anything that happens in terms of discharge, care coordination, and transitions of care that go across all the phases of care throughout the episode as it continues. And this is an example, since we're talking orthopedics here, of an orthopedic bundle coverage. The chart shows just some generic percentages on cost profiles in an unmanaged state. So this would have been before BPCI Classic. And how we would look to address the orthopedic bundle in terms of care redesign, and what we're looking for in terms of understanding the percentage of costs in the index admit, what can you do there that it would be part of ICS? What are the post-acute care costs? Are these costs appropriate? Are they not appropriate? Are the levels too high? If they're too high, what does that mean? What are we going to look for? And that's part of what's listed in the bullets below. And obviously, we'll look at readmission rate, trying to understand what the readmission causes are, where they come from, why do we have readmissions? Is there anything that we can do to reduce the readmission rate? Especially, is this something that can be done in a preoperative optimization portion where we really understand the patient and we can offset downstream readmissions by having things taken care of appropriately up front. There's a starburst next to the one, NCSF, it is non-cervical spinal fusions. The reason the starburst is here is obviously there's a vast percentage that is missing from 100%. What's not included in here is costs that are not in any one of these buckets, of which there's a lot of. But that is one that is certainly applicable to durable medical equipment, or DME. And what we find is that there is some major downstream costs. While there's very little in the post-acute care cost, there is a significant amount in DME for back braces and bone stimulators. And the question is, are those necessary? If so, are they necessary at the cost that they are? That's all to be determined, but it's other areas that one might look at. I wanted to quickly cover the legal and compliance stuff while we're doing this. Obviously, as I said before, without OIG waivers to the fraud and abuse laws, nothing in terms of care redesign and gain sharing would be possible. So the 3 major ones are listed here. There are obviously waivers within the program in order to do some of the processes that we undergo in order to create a savings pool and deposit dollars, so on and so forth. But one of the more interesting one is the last bullet here, which is beneficiary incentive waivers. And we're going to expand on that just a little bit here. But I wanted to cover, before we get to the incentive waivers, a little bit about the beneficiary and protections. Those in BPCI Classic will be completely familiar with this. The beneficiaries, the Medicare patients, Medicare A and B. Remember, this is Medicare A and B only. It is not Medicare Advantage, so on and so forth. Medicare A and B, or red, white, and blue, do have choice. And the beneficiaries always have choice as to where their providers are, and we can't change that choice. It doesn't mean that you can't lend a hand in leading them to where they, your preferred providers might be, and the rationale as to why you might have preferred providers. But they have the ultimate decision as to where they wish to go. Under normal circumstances, gifts or remuneration are not allowed. They are allowed to the extent in this program as supplied by the waivers for beneficiary incentives that will all be part of what is called the Care Redesign plan in this program. That's what I'll discuss in the next slide here. And the beneficiaries have to be notified that you as an episode initiator and the practitioners are part of BPCI Advanced. There will be a notification letter that comes out. It will be generated by CMS. I will bet you that it will have to be altered. I'll probably modify it, send it back in to get it approved. Because the last time that they did this, what they sent over, I would have personally opted out of the program for if I could have. Now, they can't do that. But the letter needs to be something that really does explain the values and why this is a good program for the beneficiary. So we'll make sure that that is the case for everybody. So for beneficiary incentives, one of the goals here is you can supply incentives to the beneficiaries that are to their benefit in terms of healthcare, but also designed to offset what could be a high-cost option for a rather lower-cost solution. And so the goal is to provide a temporary low-cost service in lieu of those perhaps facility stays at a higher cost, and place the beneficiary in the appropriate care setting, taking into account care delivery and patient safety. That is always paramount. The patient always comes first. We do not do anything in this program, at least at Fusion5, to manage to cost. We manage to patient need. And as we manage to patient need and put them in the appropriate care setting for the appropriate services, cost reductions will come out at the end. Certain examples of what you can use as waivers is providing transportation. So a patient could go home if they were going to a facility, and the only reason they were going is because they didn't have ability to get from their home to, say, outpatient therapy, that the episode initiator could provide that transportation, pay for it. It would get paid for out of the savings generated in the program because you weren't sending them to a skilled nursing facility or home with home health services, both of which would cost more than the transportation and perhaps your own physical therapy services. And the same is true for other things listed here. There is a library of these that are possible, and we will generate these along with every episode initiator on ideas. They can be changed over time. Because they exist, they do not have to be used. They are available for use for individual patients as best required. Sean, do you have any comments?
No, just the appreciation I have for the patient-centeredness of this program and what it can do. In fee-for-service, we've all experienced this, the limitations of what Medicare does and does not pay for. In a waiver-based program such as this, we can get people to an assisted living for a small respite. Whatever we need to do for that patient, it really can happen clinically. And then, as Jerry said, costs follow.
Why don't you take next step, Sean?
Sure. So we have an upcoming webinar series, and Peter will be emailing those to you. You can expect to see those about every Friday for the following week, a series of webinars that are going to be very informing. We have some face-to-face meetings. Martha has been reaching out to you for those. If you have not yet had a chance to reply, please do. A lot of detail that we need to go through, a lot of things to do. And we also have the OrthoConnect show next weekend. If you'll be there, expect an email later today or tomorrow morning. We'll be inviting you for times to come by the booth, or just feel free to come by the booth. And we'd love to connect with you. We have some opportunity analysis files there for you. So a lot to do, participating agreements, different things like that, and look for that information, and we look forward to connecting with you.
Absolutely. So continue to look for announcements for the webinars. We are intending to have a webinar each week for the next ongoing weeks. I don't even know what the number is. Trying to touch on all the key elements that we need to touch on, and they may be revised over time. All the way through and including up to implementation, which is after we've all decided who's going to go forward and in what. So we look forward to having ongoing communications with all of the groups. Again, if you have any questions, use the address info@fusion5.us for any questions that you may have. That way we can collect them all, and then we can send them out as an FAQ as opposed to trying to address questions on each individual webinar. It turns out to be, I think, an easier and more beneficial in terms of the responses as they can be distributed across the board. So we thank you for your attendance and hope to see you on future webinars and on our face-to-face meetings, which are coming up over the next many weeks. And with that, I'll conclude the webinar, and we'll open up, obviously, the email for questions. So it has been a pleasure. I know that Sean has been a pleasure as well, and you'll probably hear from both Sean and I, as well as other members of the team on each one of the upcoming webinars. So again, thank you for attending, and we look forward to seeing you again. Bye now.